Hello everyone, welcome to this finals crash course series session on gastroenterology and general surgery. I'm Ellie and we've got Izzy tonight who will both be teaching you both of these topics. And Izzy, I'll let you introduce yourself.
I'm Izzy, I'm one of the SHOs at Ealing. I'm actually on general surgery at the moment, but I'll be teaching the gastro portion of this. Feel free to put any questions in the chat as we go along. I think we have a polling thing.
So I'm just popping up the chat now. So guys, if you follow the link that we're going to pop in the chat, you can go on to the poll and pop your answers in there.
If you go on to the next slide, there's also a QR code that people can scan in if they prefer that.
Give you guys a few minutes to do that and then we'll get started.
Yeah, it's completely anonymous as well, so please do give it a go. And it does give you the option to change your answers before you we close the polls. So don't be too worried if you want to change your mind. Just put an answer in.
Cool. Let's get started with the first SBA. So I'm doing gastro. So your first question is, you see a 55-year-old in A&E. He's had 1 day of excessive vomiting. He thinks it might have started a brown colour, but now it's persistent, fresh, dark red blood that you've seen. He's got a background of alcohol excess, otherwise you don't know the rest of his background. He looks pale and his blood pressure is 80/60. His heart rate's 110 and his hemoglobin on VBG is 75. I want you to choose the most appropriate immediate management.
Okay, you can see we've got some answers coming in. We'll just give it a little bit longer. Oh, and some changing answers as well. Okay. All right, so we'll stop it there.
Yeah. So a few people changing their minds. They're all fairly valid, but the most appropriate immediate management for this is to put out the major hemorrhage protocol. He's hemodynamically unstable and actively bleeding. The most likely source, given his background, is a varicel bleed. And even if it's not that, that would be the worst case scenario. So you want to treat that. So that's with terlipressin and antibiotics. He will need an OGD within 24 hours, plus or minus going to theatre, but given he's hemodynamically unstable, you need to stabilise him and resuscitate him. So this is the British Society of Gastroenterology guidelines on acute varicel bleeds. So you can see the first box is just resuscitating them until they're stable enough to either have an OGD or to go to theatre, and depending on what they find, the appropriate management. So next question, you see a 58-year-old man complaining of retrosternal chest pain for the last 2 months. Pain's worse in the evening when lying down, and he has associated acid rash. You decide to organise him an OGD given his age. What cellular change might you see on the OGD?
That's great. We've got a mix of some answers coming in again. Okay, let's stop the poll there.
So this is just one you'll have to learn. So I'm thinking of Barrett's, and that's a squamous to columnar. So your squamous cells line your esophagus, and with metaplasia they become columnar. The other ones I've just thrown in names of other cell types. I don't know if they're actually anything in particular, cuboidal squamous, but that's a Barrett's change. Number 3, so you see a 37-year-old lady who comes to A&E with a 2-week history of dysphagia, starting with both solids and liquids, with regurgitation and weight loss of 5 kilograms. She doesn't find it painful to swallow. You get a barium swallow, which reports a classic rat tail esophagus. What is your diagnosis?
Give it a few more seconds. Okay.
Cool. So there's a bit of a clue in the history as well as in the barium swallow. So dysphagia starting with both solids and liquids, and the rat tail esophagus is achalasia. With any kind of esophageal cancers or mass or webs, you often see it starting with solids and then moving on to liquids. So this on the left is your rat tail, classic rat tail barium swallow, and on the right is what a diffuse esophageal spasm would look like. So there is contrast going the whole way through, whereas with achalasia it almost abruptly stops. Number 4, so you see a 67-year-old gentleman in gastro clinic. He recently underwent an OGD for dysphagia and weight loss. A mass was found and biopsied, and it showed a moderately differentiated adenocarcinoma invading the muscularis propria. He also had a PET scan which showed 4 lymph nodes that showed infiltration, but there were no distant metastases. What stage of carcinoma does he have using the TNM staging? Quite unanimously C there, so yeah. Nicely done. So any lymph node involvement immediately puts you into stage 3. The staging 1 and 2 would be to do with the depth of infiltration in stage 4, including metastases. This is just a bit of a visual representation of kind of the different levels. I'll just leave it there for a second so that when this goes up on YouTube, people can have a look at it.
Just to say as well, I can see quite a few people have joined sort of after we posted the VBox poll. If you want to join in the poll and you haven't already, if you click on the link, it will let you join in.
Cool. So question 5, see a 40-year-old gentleman coming to his GP with epigastric pain that improves after he's eaten. He reports an episode of coffee ground vomiting in the morning. He's a smoker. He recently sustained a muscular injury, for which he's taking regular NSAIDs, and you suspect he's got peptic ulcer disease. Where is his ulcer given the presentation? Cool. Should we, any more answers?
Yeah, we can stop it there.
Yeah. So it would be in the duodenum. I quite like these kind of questions. So the pain that improves after eating versus pain that worsens with eating. You don't necessarily see that actually when people present with it. It's not quite as good at differentiating, but they like it in questions. There's no real difference between the fundus and the pylorus in the stomach with presentation. Question 6. Which virus causes chronic hepatitis?
Okay, great. I think we can stop it there.
So Hep B causes chronic hepatitis. Hep D can cause it in concurrence with Hep B, but not alone. The rest will cause acute hepatitis. So question 7. You see a 28-year-old gentleman who has come in with fever, malaise, nausea and vomiting, and jaundice. He's got a background of, he's an IVD drug user and alcohol excess. He's got a raised AST and ALT. AST is greater than his ALT. And he has a bilirubinemia. You do a hepatitis screen. Which of these blood results indicate an acute infection?
Okay. Can see a bit of decision between two answers there.
Yeah, a bit of a split vote. So the Hep B surface antigen is what we look for acute infectivity, but for how bad the infection is, you look for Hep E antigen. So I can see why there would be some confusion with that. So you would see positive if they're infected, but we would look for the Hep B surface antigen for a current infection. The Hep B surface antibody might also be raised if they've been vaccinated for previous infections. So, but if you're looking to see if that is what the cause is, you're looking for Hep B surface antigen. And that's a little diagram to show you what happens after you've been infected. So question 8, you see a 20-year-old with a 6 month history of fatigue, reduced appetite and hand tremors at rest. On examination, he's jaundice, he has hepatomegaly and Kaiser-Fletcher rings. Given the likely diagnosis, which out of these would you see on his bloods?
Oh, I think let's stop it there.
So this is a fairly difficult question. I'm looking for reduced serum chiroplasmin because, oh, that's not meant to happen. There we go. It's B. I don't know why the other one's highlighted. So this is Wilson's disease, which you can get both liver and CNS involvement. The bloods, you get reduced serum chiroplasmin, reduced total serum copper, and actually get raised free serum copper, weirdly. I'm not entirely sure on the pathogenesis with that. And then you get an increased 24-hour urinary copper output, which is what they use as the gold standard. You manage it with penicillamine, which is a copper chelating agent. Okay, so next question. You see a 55-year-old lady who had an episode of acute hepatitis 6 months ago. She reports fatigue, anorexia, and joint pain since then. She's got no particular past medical history, but her mother had rheumatoid arthritis. You suspect she has autoimmune hepatitis, so you send off for autoantibodies, and her bloods show that she has anti-smooth muscle antibody. What type of autoimmune hepatitis does she have?
Okay. Slight split again here.
Which has anti-smooth muscles and sometimes anti-ANA. It's more commonly found in perimenopausal women. Type 2 has LKM1 and anti-LC1. You usually see it earlier in life. And type 3 is less well known about in general, and has antibodies to soluble liver proteins or the liver pancreas antigen. There's no particular demographic that they have isolated for it. Question 10, you see a 50-year-old gentleman with known liver failure. He's being worked up for a routine knee replacement, and it's noted that his clotting is deranged. Which of these clotting factors are associated with liver failure?
Okay, we've got a clear vote on this one.
Very decisive, and you're all correct. I'm impressed you all know your clotting cascade quite so well. So yeah, factors 2, 7, 9, and 10 are all made in the liver, and vitamin K is essential for their formation. So you're reviewing a 6-year-old gentleman with alcoholic liver failure in clinic. On examination, he has a tremor. He has 10 spider nevi, moderate ascites, and caput medusae. He's orientated and has no evidence of ataxia. On his most recent bloods, his bilirubin is 37, his albumin is 40, and his INR is 2.0. What would you calculate his Child-Pugh score?
just give it a little bit longer. Okay, so we've got a little range of answers here.
Yeah, so at first this does seem a bit mean, you know, I didn't give you the scoring system, but it doesn't go, so the answer is B. The child Pew score doesn't go above 15 and it doesn't go below 5. So that's where, you know that because he's doesn't have hepatic encephalopathy as well, it can't be the top score of 15. So if you know the scoring system, then you would deduce that it has to be 10, even if you don't know the exact points. Question 12. You see a 45-year-old lady who had a CT abdo-pelvis for abdominal pain. The CT abdo-pelvis incidentally picks up a liver lesion. It is 10 millimeters in diameter and in the right lobe of the liver. It's regular and there's no enhancement with contrast. What is the likely cause of this lesion?
Okay, I think everyone's answered.
So this is a hepatic cyst. They're classically found in the right lobe, classically found in females, and out of all of those, they're the only ones that won't enhance with contrast. So that's your clue from there. You see a 75-year-old gentleman who's come into his GP with a 3-month history of weight loss, painless jaundice and nausea. He's not feverish. On examination, he has a mildly distended abdomen, and given the history, his GP orders an urgent CT. Which sign on the CT would be suggestive for pancreatic carcinoma? Oh, everyone's changing their answers.
Oh, just give it 10 more seconds. Okay.
So your double duct sign is what would suggest pancreatic carcinoma, specifically head of the pancreas carcinoma. It's due to pressure on the common duct, so you get dilation of the pancreatic and CBD. The CBD filling defect would be due to usually due to a gallstone, and you would see that more on an ERCP because that's where you're pushing contrast up into the biliary tract. Whirlpool sign is fairly non-specific, and it's basically anything that's torted in the abdomen, so ovarian or bowel, anything like that. And string of pearl sign is in small bowel obstruction, I think. I've forgotten now. You see a 20-year-old gentleman who presents with 1 year of fatigue or weight loss, change in bowel habits, and abdominal pain. He's a non-smoker, occasionally drinks alcohol, and has no significant comorbidities. You organise some blood tests and a colonoscopy, and it shows inflammation within the small bowel. There are skip lesions and granular matter on biopsy, and he is P ANCA positive on his bloods. What in that history and investigations doesn't fit the diagnosis of Crohn's?
Okay, I think everyone's answered.
Yeah, and it is that he is, that's frozen, P ANCA positive, so that's associated with ulcerative colitis. P ANCA negative is Crohn's disease. The rest are classically in Crohn's disease. You see a patient in the gastro clinic, the same patient as above, and you counsel him on starting medication. He's already completed a course of oral steroids, which have improved his symptoms, and you're considering starting him on azathioprine as a maintenance therapy. Which blood test is important prior to commencing this treatment? That was an incredibly rapid response from everyone.
Yeah.
And you're all absolutely correct. TMCP is the enzyme that will metabolize azathioprine, so you have to check the levels prior to starting. You see a 16-year-old girl who is complaining of constant fatigue. She feels bloated, especially after meals, and doesn't put on any weight. She looks pale, and you do a set of bloods and she is anemic, has B12 deficiency, and has positive antibodies. Which of the following antibodies is not positive in celiacs?
I give it 10 seconds. I can see if the answer's changing.
Okay, so yeah, majority of you are correct. It's anti-LC1, which was actually in one of the previous slides, which is positive in type 2 autoimmune hepatitis. Anti-TTG is obviously the classic one that we would look for, but the other two are sort of non-specific, but they are found to be positive in celiacs as well, and can be used if anti-TTG is not positive, which happens in a small subset of patients. You see an 18-year-old gentleman presenting to A&E with 6 hours of abdominal cramps, vomiting, and watery diarrhea. He doesn't complain of any blood in the diarrhea. He's apyrexial, and he reports this happened after eating leftover chicken katsu curry that was not put in the fridge. The symptoms started approximately 4 hours after he'd eaten this. Which bacteria has caused his GI upset?
10 more seconds. Okay, so we're slightly split again.
Yeah. So with questions like this, you want to look for the clues they put in the question. So for this, it's that symptoms started 4 hours after he's eaten, which is classic of a serious infection. Some of you are thinking salmonella because of the chicken. So it's typically 12 hours after eating a raw chicken, and it's often associated with bloody diarrhea. Campylobacter is usually 2 to 5 days after eating something, and also associated with a fever. B. serous is less than 5 hours, not usually any blood in the diarrhea. And enterocolitis is 4 to 7 days after eating usually undercooked pork, and can cause lymphadenopathy. So if that's lymphadenopathy is in a question, that would be your bacteria. So next question is, you see a 21-year-old girl who recently started university. She complains of bloating, abdominal cramps and diarrhea. She's got no blood or mucus in her stool, and she has no weight loss. Her symptoms improve after opening her bowels. She smokes, binges on alcohol, and she appears very anxious to you. You suspect that she has IBS. According to NICE guidelines, which investigation should you not do?
Okay, 10 more seconds. Okay.
So according to NICE, you shouldn't do TFTs when you're suspecting IBS. Fecal calprotectin, full blood count, anti-TTG, you can all do. Full blood count, you're looking to see if they're anemic or if they've got raised white cells, things like that. Fecal calprotectin is just because sometimes it can be non-specific in IBD, that they're not coming in with weight loss or anything like that. They still suggest to do that, but you shouldn't do an occult fecal test. And they also say to do anti-TGGs as well, but you shouldn't do thyroid function tests. There are also other ones that they tell you not to do, and it's nicely on the NICE guidelines flow chart, but it's quite a common test that people do and chuck in, but they advise not to do it.
Okay, so I think we'll make a start on the second half. So I'm Ellie, I'm an F1. I went to St George's Medical School with Ash, and I'm now working down in Devon in Torbay Hospital. This is me on a night shift, I think, in my surgical scrubs, hopefully planning to apply for core training at some point in future. Any opportunity to wear surgical scrubs. Okay, fine. So the second half of the session is slightly shorter, and we're running the polls again. So the first question, so a 72-year-old woman comes to the acute surgical unit for assessment. She's got generalized abdominal pain, which is worse in the epigastrium and left iliac fossa. And her abdomen is soft, but it's diffusely tender, and her VBG is there. So what do you think the most likely diagnosis is for this lady? We'll give it 10 more seconds. Okay, so we've got a little bit of a split going, I can see. So the answer is C, ischemic bowel. So a few people put down A, which I can see why you might have gone for A. So looking at her gas, her lactate is high. So there's clearly some badness going on sort of intra-abdominally. But the difference between A and C here is that her abdominal exam is quite unremarkable. She's not peritonitic and it's soft. And this is sort of more in keeping with an ischemic bowel. Patients tend to have sort of quite a non-specific presentation, and perhaps it doesn't seem as serious as it actually is. So bowel ischemia is caused by a sudden decrease in blood supply to the bowel, resulting in ischemia, and then if it's not caught in time, death of the bowel. And some causes include an acute thrombus or embolism. You can get venous congestion or non-occlusive thrombosis. So if someone is profoundly septic, for example, and they've got really low blood pressure for a while, particularly in elderly people, they're at risk of getting hypoperfusion of their bowel. Risk factors, particularly for thrombus, include high cholesterol, high blood pressure, smoking, and AF. And the key thing to remember is that it's generalized abdominal pain, which is out of proportion to what you find on examination. So your first test of choice is going to be an urgent ABG, because you want to see what their lactate and their pH is doing. And then your next step is going to be to order a CT with contrast, which will show you edematous bowel wall, loss of bowel wall enhancement, and pneumomatosis, which is air within the wall of the bowel. And then management, we're going to give IV fluids, IV broad spectrum antibiotics, and then they really need some sort of intervention, either clot removal you can do, or surgical removal if the bowel has died, but it still has quite a high mortality rate. I think particularly because patients are sort of caught quite late, particularly if they've got sort of a generalized abdominal pain, which doesn't seem so severe. Okay, so question 2. A 45-year-old woman is brought to A&E with severe vomiting and abdominal pain for the last 24 hours. She's clammy with severe epigastric pain that radiates to her back. She's got a history of hypertension, high cholesterol, and previous episodes of biliary colic. So what's the most useful first line imaging? Okay. So we've got a bit of a split going on here again. So the answer that I was going for, although I can see most of you have gone for E, my answer was B, CT. So I'm going here for this being acute pancreatitis. I think perhaps the ultrasound sort of option, she's got history of biliary colic. We're thinking about sort of acute cholecystitis kind of picture, but the radiating into the back was kind of the key feature that I was trying to get at here. I mean, in reality, to be fair, if she came into your A&E, perhaps they would say to you, order an ultrasound first. That's a fair point. But it would be a CT that you'd need to fully visualize the pancreas. So acute pancreatitis is a disorder of the exocrine pancreas, and it's basically the pancreas sort of digesting itself. So local and systemic inflammatory response, and patients become very dehydrated in this, and they often have a lot of vomiting as well. CT is the most useful form of imaging to pick up pancreatitis. However, it is largely a clinical diagnosis. It's got some very typical features, and particularly patients with sort of high risk things in their history. So this lady's had a history of gallstone disease, so she's more at risk. And gallstones are the #1 cause in the UK of acute pancreatitis. Second is alcohol. And then you've got your lovely I get smashed, which is a really good one to remember for exams. Idiopathic, or we just don't know why they've got pancreatitis. Gallstones #1 cause in the UK. Alcohol's the second. Abdominal trauma, sometimes after blunt force trauma to the abdomen, people can get pancreatitis. Using steroids, having mumps, it can be autoimmune. A scorpion bite, which everyone loves to remember, and it's specifically a Trinidadian scorpion. High cholesterol or high calcium, ERCP, and then certain drugs, particularly azathioprine. And then management of pancreatitis, so it's usually all conservative treatment, so lots of IV fluids, lots of analgesia, lots of antiemetics. There's the Glasgow IMRI score, which sort of takes into account things from their blood results and sort of their general symptoms, and that's a predictor of the outcome. People can get really sick really quickly from pancreatitis. There are some complications that require surgery, so things like abscesses or pseudocysts. And if someone's had repeat episodes of pancreatitis, they can eventually get chronic pancreatitis, in which their amylase sometimes doesn't rise because the pancreas is so damaged, and they can also get type 3 diabetes. Okay, so question 3. So a 75-year-old patient is diagnosed with colorectal cancer, Duke stage B, and he presents with bowel obstruction and he has surgery to treat this. So what type of operation is most likely to be done for this patient? Okay, we'll give it 10 more seconds. Okay, so the answer that I was looking for here was B, so Hartmann's. I see most of you put Hartmann's. So briefly, just colorectal cancer. Majority of colorectal cancers are adenocarcinomas derived from glandular epithelial cells, and it usually presents in one of 3 ways. So either a person going to their GP with suspicious symptoms such as bleeding or weight loss, people who are asymptomatic but they're identified by a positive fecal occult blood test, or perhaps they're found to be anemic and we don't really know why, or 20% of people present as an emergency, so either a perforated bowel or obstructed. And people with right-sided colorectal cancers often have the more non-specific symptoms. In advanced sort of disease, you may feel a right-sided abdominal mass. And to diagnose, we're going to want to do a CT tap, so including the thorax, because we want to look for metastases. And an MRI is more useful if they've got a rectal tumour, so particularly if we're considering doing surgery. And here's just a brief look at your staging. So some of the older colorectal surgeons you'll see tend to still use Dukes, which is there, and it kind of correlates really to the TNM staging, which we tend to use now. So T1, tumour invades just into the submucosa, T2 invades into the muscularis, T3 into the subserosa, and then T4 it's outside of the bowel wall, and then your N is just your number of lymph nodes that are involved, and your M is with or without Mets. And then types of surgery. So the reason why it's B, so this man has presented with an obstructed bowel due to a sigmoid tumour. So the Hartmann's involves removing part of the descending colon, the sigmoid, and the rectal stump is then left inside the pelvis to let things heal, and that sort of proximal bit of colon is brought out as a temporary colostomy. They can usually join those up at a later date when the patient's more well. Anterior resections are for sort of upper rectal tumours. So it's the sort of first proximal 2/3 of the rectum, and part or all of the rectum is resected, and then the sigmoid is joined directly to the anal sphincter. So this usually means that the person avoids a permanent stoma. If they've got lower 1/3 involvement in their rectum with cancer, then they need an AP resection, which unfortunately means a permanent colostomy, because you have to remove the anal sphincter. If they didn't have a colostomy, they would just be permanently incontinent after that. So unfortunately, in those patients, it's the only option. And you've also got total mesorectal excision, which is in sort of lower rectal tumours again, and particularly if the tumour sort of invaded outside of the wall, because the surgery involves removing the mesentery as well, and any lymph nodes. And we call a clear margin sort of under 1 millimetre if under 1 millimetre is clear of cancer once the rectum's removed, then that's a better prognosis. Okay, so SBA4, so a 95-year-old man with multiple comorbidities has a large left-sided inguinal hernia, and he's not really keen to have an operation. What's the best option for him? Okay, 10 more seconds. Okay, great. So I can see that the majority of people have put C. So C is the right answer. So offering him a truss device, which is kind of a sort of a binding pair of boxer shorts, if you like, to sort of keep his hernia in place. And the reason that would be more appropriate than A, which some people put, it is a large hernia. So, you know, and he's come to sort of seek help for it. So it's clearly sort of, we're assuming that it's bothering him, and that is an option. It might be that he doesn't get on with the truss device, in which case we could just watch and wait, but it's certainly something that he could try first. He definitely doesn't have to have surgery. Prophylactic antibiotics are not really going to help. And then district nurses, I mean, if he was sort of not managing with his hernia, that could be an option, but there's nothing to suggest that at the moment. So an inguinal hernia, so any hernia is an abnormal protrusion of the viscus or part of the viscus through a weakness in its containing wall. Inguinal hernias can be congenital or acquired, and a hernia is composed of a sac, which is usually the peritoneal lining, the neck, which is the actual defect in the abdominal wall, and then its content. So it can just be a lump of fat in the hernia, or it can be bowel. And we tend to offer surgery if the hernia is large or causing symptoms. Obviously, if the patient is unfit for surgery or doesn't want to have surgery, we can offer them a truss, or we can watch and wait. And here is sort of the main difference between a direct and indirect inguinal hernia. So a direct hernia is sort of more common in elderly people, and that is due to a weakness in the muscle wall. You can see that on that diagram there. Indirect hernias are the ones that occur in young children, so that's failure to close during the descent of the testis, so more common in baby boys. And and that's the hernia actually going down through the inguinal ring. So direct hernias tend to be acquired due to sort of long-term muscle strain and things like that. Indirect tend to be congenital, and the indirect hernias are sort of more likely to strangulate because they're going through that internal inguinal ring. So they will be offered to have surgery, usually when they're an infant. And then direct hernias are sort of less likely to strangulate, but as we've mentioned, we may offer surgery if it's large or symptomatic. And then just some general terminology about hernias, and this applies to all hernias, not just inguinal ones. So if they're reducible, then they can be fully restored to the abdominal cavity, either on their own or they can be manipulated back in. And patients often can manipulate their own hernias to go back in. If they're incarcerated, then part or all of the hernia can't be reduced, and there's a high risk then of it strangulating. And strangulation is when the blood supply is cut off, and it's usually the tight neck that causes the strangulation. An obstructed hernia is when there's a loop of bowel within the hernia that's now kinked, and that again usually goes on to strangulate. And the process of sort of a strangulated hernia is here. So you get venous occlusion, you get swelling and edema of that bowel in the sac. This then impedes blood flow and leads to bowel damage. Okay, so next question. So a 57-year-old woman goes to her GP with crampy upper abdominal pain. She's had these episodes for some time. However, the pain has become constant and she now feels nauseous with a fever, and she's acutely tender on palpation over the right upper quadrant and epigastrium. So her blood tests show a mildly elevated white cell count and CRP, and the rest of her bloods are normal. So what's the most appropriate management for her at the moment? Okay, we'll give it 10 more seconds. Okay, so I can see most people have put D, and we'll go through why. So the answer is B. So this is acute cholecystitis. She has got a fever and she's got mildly raised inflammatory markers, but she's not, the rest of her bloods are normal. There's no sign from the information we've been given that she is sort of septic from this. So what we can do at the moment is give her an oral antibiotic and get her an urgent ultrasound scan. Now, with these patients, it's really important to sort of give them the correct advice. So at my hospital, for example, we'll see people in the acute surgical unit. They'll have these sort of symptoms. And if they're sort of with it and they are sensible, we can say to them, right, we're going to give you these antibiotics. We're going to bring you back tomorrow morning for an ultrasound scan. And then if it confirms acute cholecystitis, we can go from there. If the patient is obviously more unwell, so her white cell count or CRP were really high, she had any signs of sepsis, then D would definitely be the right answer there. But at the moment, I don't think she is quite sick enough for that. E, obviously, she is probably going to be added to the elective surgery waiting list, but we need to treat her problem first. It's not really appropriate to watch and wait. And emergency surgery is, again, maybe on the list, but we need to wait and do some more things first. So acute cholecystitis is infection and inflammation of the gallbladder, and it's usually due to obstruction due to stones or sludge. Milder symptoms, we can give antibiotics. Oral antibiotics are sometimes okay. Then get an ultrasound scan and then consider doing a lap chole in the near future. And as I said, if you're sort of safety netting the patient, you have to be really clear about if your symptoms get worse, if you're taking these antibiotics and they're not helping, then you must come back to us straight away. While they're waiting for surgery, and this is bearing in mind as well that with the NHS, unfortunately, as it is with COVID, people are waiting longer for sort of semi-urgent procedures. So you can tell them to avoid fatty foods, keep well hydrated. If they're severely unwell, they're going to need IV antibiotics and urgent surgery. And acute cholecystitis is usually preceded by episodes of biliary colic, which is typically intermittent right upper quadrant or epigastric pain, nausea, and the symptoms are worse after fatty meals. On examination, you've got Murphy's sign, which is pain on inspiration when the gallbladder is palpated, and on an ultrasound you'll see a thickened gallbladder wall. So then we've also got a further complication of gallstones, which is ascending cholangitis. So I thought I'd just mention this because it is a differential for sort of fever and right upper quadrant pain in your exams, and it tends to be a triad of right upper quadrant pain, rigors, and jaundice. These patients are usually very, very unwell. They've usually got deranged LFTs and raised inflammatory markers. They definitely need to come into hospital and be on IV antibiotics, and they urgently need a scan to confirm. And then an MRCP is usually done that allows us to visualize the biliary tree, and then we do an ERCP to remove the stone that's causing the obstruction and place a stent. Okay, so SBS 6, a 7-year-old boy attends A&E with his mum and he's complaining of abdominal pain. On examination, the pain is worse in his right iliac fossa. He's not distressed and he's able to jump up and down. His mum said he's had some loose stools, and in the last few days he's developed a mild dry cough, and he's got a fever of 38.9. There's his bloods. And what do you think the next most appropriate test would be? If you're not sure, just have a guess. It's completely anonymous. I can just see the amount of people who've answered which question. We'll give it 10 more seconds. Okay, so I feel like people are a little bit unsure on this one. So the correct answer is A, and I'll go through why in just a moment. So appendicitis, if you work shifts in any sort of surgical jobs in F1 and you're asked to see a child with right iliac fossa pain, I can count on sort of one hand the amount of times that it has actually been appendicitis. Children very, very commonly have tummy pain, and it becomes a little bit of a skill, sort of how do you differentiate between tummy pain and actual appendicitis. So right iliac fossa pain is a very common presentation in younger children, and young children particularly can find it hard to localize pain. And sometimes you have situations where there's a parent who is obviously quite worried that this is appendicitis. The GP's probably said, I think it's appendicitis. And the parent sort of encourages the child to give you answers that sort of lead you towards appendicitis. So you need to rely on your clinical signs. So psoas sign, Rosving sign. Psoas sign is pain in the right iliac fossa on extension of the hip. Rosving sign is pain when the left iliac fossa is pressed. You feel pain in the right. And also in the right iliac fossa if they've got any localized peritonism or involuntary guarding. Features that are favourable for appendicitis. So their white cell count and CRP tend to be sort of moderately raised, not really, really high. They've usually got a low grade fever. So this boy has got quite a high fever of 38.9. Children with appendicitis are usually it's sort of sitting around the 38, sort of grumbling fever. And the pain classically starts centrally and then moves to the right iliac fossa. So considering other diagnoses, if they've got change in bowel habit, so he's had some loose stools, he's got a very high fever. If they've got any dysuria, then we want to consider a UTI and definitely do a dip. Or if they've got upper respiratory tract infections, really important thing to consider, and why I put A is COVID-19. A lot of children are getting sort of mesenteric adenitis, which is painful inflammation of the lymph nodes in their abdomen as a result of COVID-19. And a lot of the kids that I've been referred to see as query appendicitis have actually ended up having COVID. In the end, COVID-19 swab's going to be the first thing you're going to do, but in reality, going back to the options, you are probably going to go on to do those other things as well, particularly if the swab is negative. So we do a urine dip pretty much on everybody that comes through, and an ultrasound abdomen. If we're still not sure before we go in to operate, we would definitely want to do one. But I think a swab would be the first thing you would do in this instance. And then here's just some signs that you might hear that's good to know for your exams. So we've mentioned Murphy's sign earlier, we've mentioned Rosving's. Obturator sign is pain when you flex and internally rotate the right hip. So as we've mentioned, McBurney's point is pain felt at the point 2/3 the distance from the navel to the right ACIS. And then some other signs that are not appendicitis. So Courvoisier's law, a painless palpable gallbladder is unlikely to be gallstones, i.e. it's something more sinister such as pancreatic cancer. Cullen's sign is bruising around the umbilicus, and this is quite a severe sign that can suggest either retroperitoneal hemorrhage or hemorrhagic pancreatitis. And then Gray-Turner's sign is sort of flank bruising that's associated with sort of bleeding the abdomen. So again, pancreatitis or even a ruptured AAA. So a 65-year-old man attends the acute surgical unit to be assessed, and he's got worsening left flank pain. He's had no urinary symptoms. He's known to have diverticulitis, and he's had some loose stools recently, but he's not bleeding. His bloods are normal. They're his OBS and his past medical history. What's the most appropriate next step? give you a little bit longer. Just have a go and we'll go through all of them in a moment. Okay, so I've got pretty much a 50-50 split between A and B. So the answer that I was looking for here is B. And the reason why is at 65 or so, particularly in elderly men that have come in with left flank pain, a low blood pressure and tachycardia, there's something that we really need to rule out first before we do anything else, and that is a AAA. Men at 65 are given an invitation to a national screening programme for a one-off ultrasound of their abdomen to look for AAA. He's just hit the 65 mark, so he is sort of within that at-risk group. But generally an acute abdomen, so presentations that require urgent intervention, bleeding, so major emergencies such as AAA, and then there's things that are a slower rate of bleeding, but they still need urgent surgery, so a ruptured ectopic pregnancy, a bleeding gastric ulcer, trauma to the abdomen, and sort of signs that we're looking for, red flag signs, low blood pressure, high heart rate, a sudden drop in HB or a rise in urea that's not in keeping with the EGFR, or any PR bleeding, or hematemesis as well. Perforations, a perforated viscus or an intra-abdominal infection needs urgent intervention. The patient is often lying really still on the bed, they're peritonitic, they've got a rigid abdomen with absent bowel sounds. And then an ischemic bowel is that raised lactate that we mentioned earlier, low pH, and a pain that's out of proportion to clinical signs. Other presentations that need attention, but they're not quite as urgent as the ones before. So colic, so any pain that sort of comes and goes that suggests an obstruction in a system somewhere, whether it's biliary, ureter, or bowel. And then peritonism, which is different to peritonitis. So like with appendicitis, you've got localized peritonism, so sort of guarding and tenderness around a particular point, but the abdomen as a whole is still soft. And then here, this is just from Teach Me Surgery, which is a really useful resource, the sort of areas of the abdomen and the diseases that we're looking for there. So I'll just leave that up for just a moment. And the link there below is just the page that Teach Me Surgery does on that. Okay, so there's just a couple more questions to go. So SBA8, a 30-year-old woman attends the surgical assessment unit and she's got pain around her back passage. The pain is a lot worse on passing stool and she's been avoiding going to the toilet because of the pain. She's noticed some bright red bleeding in her stool. What's the most appropriate first line management? Okay, we'll give it 10 more seconds. Okay, so the answer that I was going for was A in this case, so topical GTN. So this lady is presenting with what sounds like a fissure, And if the pain is to the point where she's avoiding going to the toilet, we really need to give her some treatment for that. So topical GTN is the first line treatment. We would also prescribe her laxatives and offer her dietary advice. I can see why you put those answers. But what's really going to treat her fissure is the topical GTN. And then here's just a differential of some anal lesions. So anal fissures tend to be sharp pain on passing stool. The pain can last for a couple of hours after the bowel movement, and it's often associated with constipation. So it's a bit of a catch-22 for these patients, because having constipation means you're more likely to get a fissure, but then once they've got the fissure, going to the toilet so painful, they're then avoiding going to the toilet. They become more constipated. So it's just a bit of a cycle. The main management is topical GTN, or we can use topical diltiazem. And the main complication is a fissure that becomes chronic and just doesn't heal, in which case we might look at some surgical options. Other lesions include hemorrhoids. So these are usually swellings around the anus. They're not usually painful unless they thrombose. They might be itchy or feel a bit uncomfortable. And they're also more common in constipation and also pregnancy. Treatment for hemorrhoids, we can put on topical hydrocortisone, which is sold over the counter as Anusol, or we can put a rubber band around them until they die and fall off. Complications, thrombosis, so a hemorrhoid that sort of becomes strangulated. There's not anything that we can really do for these patients other than give them sort of analgesia, advise them to put an ice pack down below, give them sort of a cushion, a ring-shaped cushion, while it settles down. But once it's thrombosed, the hemorrhoid is effectively, it's banded itself, so there's nothing else that we would do at that point. Hemorrhoids can bleed as well. They can present with sort of acute sudden PR bleed. You can also get pilonodal cysts. So these are swellings found at the top of the nasal cleft. We usually advise conservative management, or they can be surgically removed if they're particularly painful or annoying. And you can develop a pinealoidal abscess with or without systemic illness. And at that point, they're going to need surgical incision and drainage and antibiotics. And then you can also get perianal abscesses. So these are sort of pain and swelling adjacent to the anus, particularly at risk people with things like diabetes, and the patient will be in a lot of pain. It'll be really uncomfortable for them to sit down, and these need treating with antibiotics and incision and drainage. And the complication that can come from these is a fistula from the abscess into the rectum, which can be quite nasty. So an 83-year-old man who's undergoing chemo for pancreatic cancer comes to A&E. He's had vomiting for the last 24 hours and he's not opened his bowels for 2 days. He can't remember whether he's been passing wind or not. He's cachectic, his abdomen's distended, and he looks mildly jaundiced. So this slice of his CT particularly, what does that show? Okay, so well done to you guys that got this, because at med school, you don't see too many CTs, but the answer to this is C. There's a gastric outlet obstruction, and that slice of CT there, both of those sort of filled sections that you can see on the right and the left, they're both stomach. So literally if you kept scrolling on that CT, you would see it go all the way across. That stomach is just so massive. And this is sort of caused, particularly in pancreatic cancer, by the tumour progressing and blocking off the duodenum. So it's possible that, you know, A may also be true if we keep scrolling, but it's not the main thing that we can see on this slice. So just briefly, pancreatic cancer and its surgical management. So unfortunately, it's often diagnosed as a late stage, and patients are often not suitable candidates for surgery. And features that they have often at diagnosis are obstructive jaundice, abdominal pain that radiates to the back, and weight loss. And by the time they've got obstructive jaundice, that's often sort of a sign that the tumour is big enough that it's going to have metastasised. If the pancreatic cancer is caught early enough, so the tumour is confined to the pancreas with no invasion into adjacent blood vessels and no more than 3 lymph nodes are involved, we can consider doing a Whipple's procedure. So the Whipple's procedure is here on the right. The sort of lots of bits are removed and sort of stitched back together. It's a very, very complex operation. It takes many, many hours, and the operation itself has about a 15% mortality rate. So we need to be really sure that these patients are going to benefit from that before we take that chance. If unfortunately they're not suitable for surgery of this kind, we can do palliative surgery. So bypass surgery to sort of relieve things like outlet obstruction. Or we can put a stent, and stenting is usually done by the gastroenterologists rather than the surgeons. They can stent either the biliary tree or they can stent the gut where the tumour is blocking. Okay, and then this is the last question of the evening. So a 27-year-old patient attends A&E with a history of IBD. She's got frequent episodes of bloody diarrhea up to 10 times a day. She's pyrexial, she's tachycardic, and she's lost 4 kilos in weight over the last several months. So what scoring system is used to assess severity of an acute flare of UC? Okay, fantastic. But everybody has gone for the right answer, which is D, so it's True Love Wits. And just briefly, the surgical management of IBD. So True Love Wits is specifically for UC. A person presenting with acute flares of ulcerative colitis in hospital, we're going to be giving them IV steroids and IV immunomodulators, such as cyclosporin or TNF alphas like infliximab. And then if these fail, we're looking at surgical options. So this is another lovely little table from Teach Me Surgery, sort of telling you the key difference between ulcerative colitis and Crohn's. So types of surgery that we can do for both of these conditions. So for ulcerative colitis, if a patient is acutely unwell, we will probably do a subtotal colectomy and ileostomy. So patient is really sick, they need surgery sort of immediately. It takes a lot of time and sort of surgical skill to remove the rectum because it's sort of right down in the pelvis. There's lots of other organs that are surrounding there and nerves and things, so it takes quite a lot of time. And somebody that's quite sick, you don't want to be keeping them under anaesthesia for very long. So what they'll do very often is just take most of the colon, leave the rectum and bring out an end ileostomy. And then later on down the line, when the patient's well, they can do removal of the rectum. And when they remove the rectum, there's 2 options. They can either remove the rectum and make a permanent end ileostomy, or they can do an IPAA. Patients sometimes call this a J pouch, and that is removal of the whole colon and rectum. And then a pouch is made from the end of your small bowel and stitched into the anal sphincter. It's a long operation. It takes about 6 or 7 hours, but it does mean that the patient avoids having a stoma in the long term. And then Crohn's, because it can affect sort of the large and the small bowel, there's quite a few different operations for Crohn's. So if they've got a stricture and it's small, then you can do a strictureplasty, so just widen that little bit of bowel by making a long ways incision. You can resect strictures, you can resect parts of the colon and the ileum, or if they've got really severe disease, particularly in the colon, you might consider a subtotal or total colectomy. Unfortunately, these patients are not suitable to have a IPAA done because the disease will just come back in the pouch. Great, and that is the end of my questions. Does anyone have any questions? Please fill in the feedback form by scanning the QR code. It really helps us out and planning future sessions as well.